Okay, so good morning, good afternoon, good evening from wherever you are joining us today. My name is Camille Pottinger, and I serve as a health specialist within the Division of Neuroscience here at NIA. I am joined today by my colleague, Dr. Miriam Gale, who is a program director within the Population Studies and Genetics branch of the division. I would like to invite you today to the Minority Health and Health Disparities in Neuroscience webinar series. This series highlights opportunities for NIA grantees and other interested individuals to share research advances, lessons learned, and opportunities in the field. Before introducing our speaker for today, I would like to let you know that at the end of the presentation, we will have a time for questions. Please submit your questions and comments through the Q&A box, not the chat box, but the Q&A box, and Dr. Gale will ask your question on your behalf. Any questions we do not get to today, please feel free to follow up with the speaker directly. Additionally, this webinar is being recorded, and we will send to all the attendees within the next week or so the video recording of this webinar. And the speaker has also agreed to let us share the slides as well. So you will get both. So without further ado, it gives me great pleasure to introduce Dr. Bei Wu, the next speaker of our webinar series. The title of her presentation is Aging, Alzheimer's, and Oral Health Disparities, Interdisciplinary Approaches. Dr. Bei Wu is the Vice Dean for Research and Dean's Professor in Global Health at NYU College of Nursing, as well as an affiliated professor at NYU College of Dentistry. She is widely recognized for her expertise in large-scale data analysis and behavioral interventions. As principal investigator, Dr. Wu leads two ongoing NIH-funded clinical trials, one aimed at improving health incomes for Chinese and Korean dementia caregivers, and another focused on enhancing oral health in individuals with mild dementia. Additionally, she directs an NIH-funded R01 study investigating the connections between oral health and dementia subtypes, with particular emphasis on biological pathways and social determinants. An internationally recognized leader in gerontology, Dr. Wu has made significant contributions, has made significant contributions through her interdisciplinary research. She has authored over 400 peer-reviewed publications, primarily focused on dementia, caregiving, geriatric oral health, and cognitive impairment. Her numerous honors include being a fellow of the Gerontological Society of America, the New York Academy of Medicine, and an honorary fellow of the American Academy of Nursing. Dr. Wu's accolades include the Distinguished Scientist Award for Geriatric Oral Research from the International Association for Dental Research, the 2023 Maxwell Pollock Award for contributions to healthy aging from GSA, and the 2024 Public Service Award from the American Association for Dental, Oral, and Craniofacial Research. So welcome, Dr. Wu. Thank you so much for presenting today, and I will hand it over to you.
You are muted.
Oh, sorry. Hold on 1 second. Let me put this slideshow. Thank you, Dr. Pottinger, for your introduction. Thank you to the NIA Division of Neuroscience for the opportunity to present this talk. I also want to thank Dr. Martin, Dr. Gallia, and several others from NIH for their support in organizing this webinar. So I made the title a bit a slight change. Instead of Alzheimer's, it's more also replaced with cognitive impairment, because this is kind of in a much broader kind of concept. So my talk is focus on aging, cognitive impairment, and oral health disparities. Really kind of using interdisciplinary approach to address these important concepts, issues in the United States. My talk also reflects more than 20 years of of research in this area. So, so I actually got a lot of questions about why actually you are conducting some oral health related research. And certainly I'm not a dentist. So just kind of share this kind of a story with the audience that how I got to kind of interested in oral health research among older adults. So I started my career as a tenure track assistant professor at West Virginia School of Medicine. So as you know, many of you in the audience knows as an assistant professor, tenure track assistant professor, facing the pressure to kind of secure external funding for research. So this is really kind of serendipity for this, how actually that I got interested in this journey, think about conducting oral health related research. So when in 2003, I chaired a session at the GSA on addressing health disparities among older adults. So GSA newsletter highlighted this session. So our symposium drew a large group of audience there. So at the end of the session, one of the individuals came to me and introduced herself as a National Institute for Dental and Craniofacial Research program officer. That her name is Ruth Nodja-Kramer. She was in charge of the oral health disparity program at NIDCR. So she actually said, she asked me whether I have any experience of conducting oral health research. I said, no, I don't have any experience. Then she actually said that there's a few researchers in the United States actually in doing this kind of research among older adults. So she also said that NIDCI was about to issue a PA program announcement that encouraged scientific community to submit grant applications to NIDCR with aging focused. So having this, so I actually, my immediate kind of reaction to her is like, wow, would be a wonderful opportunity. So I said, like, if NIH has this kind of funding, I certainly would like to take the opportunity and think about some potential projects. So that's actually how I kind of started this this journey, and so. Because my kind of long-standing kind of research interest is always on dementia, cognitive impairment, and caregiving. So I was thinking like how actually I can link this, my kind of dementia interest on dementia, caregiving, with actually oral health. So at that time, kind of my hunch, my instinct was like, it would be interesting to link oral health and conduct some research, look at actually oral health and the cognition, cognitive function. So that was actually, that's how actually I started conducting this line of research, combine my interest in dementia with oral health research, launch a kind of unique research focus that actually has been for literally actually two decades now. So that's so basically just my kind of message is that you can keep your research interest, but also trying to kind of develop new research areas that can tap into your kind of existing research interest, your research skills, and kind of go into a new territory in that sense. So, so poor oral health, that this is a really common but often neglected problem in older adults. When we think about chronic diseases, poor oral health, like tooth decay, these are really actually the most common chronic conditions that actually people may not particularly recognize. So based on National Health and Nutrition Examination study, found the recent one that found 20% of the older adults in the United States, 60 and above, had untreated cavities. 20% had indenturism. That means actually complete tooth loss, natural tooth loss. And 68% had gum disease, which is the periodontitis. So this is very common chronic conditions in the United States. So, but when we also think about what are the common kind of oral health problems and the conditions among older adults, this is xerostomia, like a dry mouth. It's that depends on kind of estimate can range from 29% to 40% or so among older adults, xerostomia. Root caries, tooth sensitivity, oral cancer, periodontal disease, gingivitis, halitosis, and cracked tooth. So these are common oral health problems and the conditions among older adults. So oral health disparities. Oral health disparities is really a persistent issue in the US. Given there's no publicly funded dental insurance, oral health disparity reflects some of the most challenging issues in the United States. That lack of access to healthcare, lack of dental insurance, and the disparities in socioeconomic status, that so many research have found that the low socioeconomic status is associated with reduced access to dental care due to cost, lack of insurance, and the competing priorities for resources. And the racial and the discrimination. Discrimination can be many. One of the discriminations is racial ethnic discriminations that systemic racism and implicit bias in healthcare, and also age discrimination. Older adults may face barriers to dental care due to assumptions that poor oral health is a normal part of aging. And also think about urban versus rural disparities. Geriatric locations can influence access to dental care. So these are really some kind of common, most challenging issues in the United States. So this figure that my colleague from England did using the English longitudinal survey of aging and conduct a study, and these researchers found that there was inverse graded associations between socioeconomic position and edenturosis. That means complete tooth loss. So with proportionally more edentate participants at each lower socioeconomic level. As you can see, the individuals at the lowest socioeconomic positions, that they actually had the highest proportion of being edenturous. So for this wealthiest, the wealthiest individuals, they have a lowest proportion of edenturism. So I thought actually this is a quite kind of interesting way to show that the graded association between socioeconomic position and the edenturous. Then oral health related problems are understudied in the field of geriatrics and the gerontology. That's how I was actually recruited by NIDCR program officer to start my research in this area. And oral health is an essential element of healthy aging. This is, I'm going to talk in the next slide about GSA Oral Health Work Group's initiative. And also increasing evidence shows that oral health is associated with systemic health. So in 2016, Gerontological Society of America formed an oral health work groups. Why I had the unique opportunity to contribute as the only non-dental professional in this work group. The other 5 wonderful colleagues are all from dental field. So in 2017, we published a white paper titled Oral Health, an Essential Element of Healthy Aging. So this paper was actually shared with all attendees at the GSA at that time, essentially, IAGG and the GSA conference, it was jointly actually hosted the conference in San Francisco. So this paper was distributed to all attendees in the conference. So that shows the GSA's effort in kind of promote oral health research in the gerontological field. So oral health and systemic diseases, increasing evidence suggests that there are associations between oral health and these conditions, such as cardiovascular diseases, diabetes, respiratory diseases, stroke, osteoporosis, and depression. That 15 years ago, our team received the funding to particularly examine social support, depressive symptoms, and oral health. And we found the long-term depressive symptoms as a detrimental effect on poor oral health among older adults. So tooth loss in relationship with disability and mortality, our colleagues, Paul Holman Pedersen, their group using EU's data and found that tooth loss is strongly and independently associated with onset of disability and mortality in older age. And my colleagues and I, we used health retirement study and found the tooth loss, self-reported tooth loss, as strongly and independently associated with onset of disability. So we think that tooth loss may be an early indicator of accelerated aging, but certainly more research need to be conducted in this area to look at whether there's any causality. Is a causality that the direction of causality certainly is unclear at this point. So now the topic today's topic is aging, oral health disparity, and the cognitive impairment, Alzheimer's. So here I want to actually show one of our studies published that actually really kind of provide a very clear message of how oral health disparities kind of persistent in the United States. So this paper is on oral health and diabetes, age, period, and cohort analysis. So we use the data from the 9 weeks of the National Health and Nutrition Examination survey. That between we link these 9 weeks of data together. Was looking at between 1971 to 2012. So included 37,000 some individuals, dentate individuals. That means with at least one permanent tooth. These ages 25 and older receive an oral examination and were included in the study sample. So this figure is really actually conveying 3 messages here. The first, so here, the solid line are all those individuals with diabetes. The dotted line are those individuals without diabetes. So that you can see here have individuals non-Hispanic white, Mexican Americans, and non-Hispanic blacks. These are 3 groups of individuals with and without diabetes. So here that during this 40 years period, there was a significant decreasing trend in the number of teeth lost. So overall, actually in the United States, this is a positive message is that individuals' oral health status is has been improving. So that's actually because you show that tooth loss, number of teeth lost is actually decreasing. But also think about that adults with diabetes that experienced about twice the tooth loss as did those without diabetes. So that message is also clear that the solid line is all actually above this dotted line. The solid line is those with diabetes. So regardless of which group you you were at. So it's basically that for diabetes, you have diabetes that you have a kind of a high likelihood of loss, a high number of tooth loss. So that's what the second message here. But also think about racial ethnic disparities. All these kind of lines didn't cross over. So that means that racial ethnic disparities in tooth loss was persistent over time, over 40 years period. Your relative positions basically was quite similar over this 40 years period. So again, that the message is saying that adults with diabetes experience about twice the tooth loss as did those without diabetes, but there was a significant decreasing trend in the number of teeth lost among non-Hispanic whites with diabetes and the non-Hispanic blacks with diabetes. So, but racial ethnic disparities persist. So in the next kind of many slides that I will particularly focus on the relationship between oral health and cognitive impairment, and really kind of have also talk about historically how this kind of work started and until now, like close to 20 years of work in this area, and particularly highlight what our team has done. So in 2007, that we using National Health and Nutrition Examination survey, we conducted one of the first studies looking at cognitive function and the dental care utilization among community dwelling older adults. So we found that for those individuals, higher level of cognitive function. Now, people know that an enhance is a repeated cross-sectional study. So it's not longitudinal. So we can only see the kind of association. So for individuals with a higher level of cognitive function, they're actually regular dental visit, the frequency of regular dental visit was also higher. So that's almost kind of, it's also graded association. The higher cognitive function, the higher frequency of preventative dental care visit. But then in 2008, that we conducted another study, and particularly using the same data set, the National Health and Nutrition Examination survey, because this is only one of the few large epidemiological studies have clinical examination data on oral health. So our study showed that cognitive function was associated with oral health. Individuals were controlling for many key confounders. So individuals with lower cognitive scores had a higher number of decayed and missing teeth and a higher proportion of periodontitis sites. So that so this is one of the first using large data set and looking into this and the association between oral health and the cognitive function. So then actually at that time, 2006, we received funding from National Institute of Dental Craniofacial Research, and we conducted a study in West Virginia among 327 individuals, older adults, and most of these the participants were from rural areas of West Virginia. So I want to highlight 3 studies here. That in the first study was looking at the cognitive function and the oral health related quality of life in older adults. We actually, this study funded the research, we were able to have extensive cognitive function measures and had a clinical diagnosis of individuals, which is whether cognitive normal, have a CNID that SIND, cognitive impaired, not demented, as well as mild dementia and moderate dementia, that stage. So we were able to, which is different from enhance, which has a very kind of gross cognitive function measure. But this study, we have clinical evaluation of oral health, as well as extensive assessment of cognitive function. So can look at the different level of kind of cognitive impairment as well. So in this study, in the study, we found that participants with normal cognitive function had a better oral health-related quality of life than participants with cognitive impairment without dementia and mild dementia. So we're able to compare this mild dementia and cognitive and the dementia. We found individuals with normal cognition has a better oral health-related quality of life. So the difference remained significantly after controlling for socioeconomic health status and comorbidity and the clinical dental status covariates. So the second paper, we found that individuals with dementia were less likely to visit a dentist regularly, and more time had passed since their last dental visit compared with individuals with normal cognitive function. So a perceived greater social network and having dental insurance was associated with increased dental care utilization. So the third paper that we examined the mediation effect of oral hygiene on the relationship between cognitive function and oral health in older adults. So this paper showed that more severe cognitive impairment was related to poor oral health outcomes and less frequent toothbrushing and flossing. That means it's not only actually they had the poor oral health outcomes, but also they had the poor oral hygiene behavior. So toothbrushing serves as a mediator between cognitive impairment and oral health outcomes. So these are actually our study that using that we collected our own data in West Virginia and showed these kind of looking into MCI, cognitive impairment, impaired, not demented, and mild dementia in comparison with cognitive, with individuals with normal cognition, and how their oral health status look like, and also their oral toothbrushing behaviors. So these findings is really build a foundation for us that we conduct later in conducting clinical trials. Why we actually, how we focus on MCI and mild dementia. This is really built on our own data collection as well as large epidemiological studies. So then actually after 2008, that certainly we see this increasing number of studies across the globe actually now start looking into oral health and cognitive function. So in 2016, we conducted a study looking at actually the systematic review, look at oral health and cognitive function. So this systematic review received hundreds of media coverage, and the people were very interested in this line of research. So the overall findings that we found that the findings on the relationship between oral health and the cognitive function at that point was inconclusive. A lot of studies were still using a small sample size, many self-reported oral health status and limited cognitive function measures, all these kind of limitations. So we particularly made the point that I think this study, this field is very, very promising. So then that my colleagues and I looked into how this tooth loss, periodontal disease, and the mild impairment among Hispanic Latino immigrants, and looking into the moderating effect of age at immigration. So so here is we used the data from the Hispanic Community Health Study of Latinos, and its ancillary study, the study of Latinos investigation of neurocognitive aging. So overall, the final sample for this study is 5,700 individuals, immigrant population. So in this study that we found that there was an increased risk of having a mild cognitive impairment for those immigrants who had significant tooth loss. Significant tooth loss we identified is as kind of eight, at least kind of 8 tooth lost. And immigrant to the United States at age 35 to 40 years old, in comparison to those who immigrate at a much younger age, at age 18 or younger. So here that you can see that there's this, we had 4 age groups depend on when they immigrate to the United States. The first one, group 1, is at age younger than 18. Then group 2 is age between 18 to 34. Then the third, 3, actually the highlighted one here in red, kind of a box here, is for those age migrate to age at age 35 to 49. Then the fourth group is those age 50 and above. Then the red line is for those actually had a significant tooth loss. So you can see from here, there's a higher risk of, and the vertical line is the predictability of MCI, proportion of MCI. So there's a higher risk of mild cognitive impairment for Latino Hispanic immigrants who have significant tooth loss, and immigrant to the United States between the age of 34 to 49 years old. So that actually can see is pretty, is quite actually striking. Think about the differences here. So that age at immigration moderates the association between significant tooth loss and the MCI, with immigrants age 35 to 49 being at a higher risk. So adult Latino immigrants have a higher risk of MCI than child immigrants. It's potentially, we think, is maybe due to limited education and the career opportunities. So poor oral health and the mental health may also contribute to the higher risk of MCI among adult immigrants. So this paper was published at the Journal of Gerontology Medical Sciences. So that actually the editor thought this paper was very interesting, so wrote a commentary on this manuscript. In this, so in this commentary, it says that the paper highlights the need to understand the diverse segments of the Hispanic population that may be underrepresented or overlooked when utilizing data from other national surveys. It also emphasized the importance of promoting optimal oral health among older adults as a key component of promoting healthy aging, which may help mitigate the development of MCI. So the commentary was quite kind of nice, and particularly think about this can be a key component of promoting healthy aging. So then actually in 2000, over time, you can see more and more papers coming out from Japan, from European countries, from the United States, and some also from China as well. So then we actually did another study system. That we conducted a study here looking at the Chinese American immigrants in the United States. Look at for this study, we examined the association between oral health symptoms, which is tooth and gum disease symptoms, and cognitive function changes among community dwelling U.S. Chinese old adults. So we use the PINE data, which is use a 2-wave of PINE data that is from population study of Chinese elderly in Chicago. That's a PINE data. So a total of 2,713 Chinese immigrant old adults were included. So with a mean age of 70, close to 73 years old. So measurement, we have a self-reported health teeth and the gum symptoms. Using cognitive function was assessed using in 3 domains, and the global cognitive function was also evaluated through a composite measure. So this study found that actually oral health symptoms and the conditions are very common among Chinese older immigrants. Close to 48% of participants reported teeth symptoms, and close to 19% reported gum symptoms. So if you add them together, it's close to 2/3 of the participants had some reported oral health symptoms. So we found that these symptoms at baseline was linked to a significant decrease in global cognition and episode memory scores in the follow-up waves. Then participants with these symptoms showed a faster rate of global cognitive decline over time, though this effect was kind of lessened after adjusting for covariates, but it was still significant. So overall, these oral health symptoms are associated with cognitive decline among Chinese immigrant older adults. The findings suggest the need for policies that focus on oral health and dental care as a means to support cognitive health in this population. Then we in 2021, we recognize that the increasing number of studies coming out, even actually after our review, which our first review was conducted in 2016, and our second review that actually was conducted in 2021, because even during that period of time, kind of many more papers being published. So in this review paper, we are able to do some meta-analysis, look at tooth loss. So this paper that we found, older adults with more tooth loss had a 1.48 times higher risk of developing cognitive impairment and 1.28 times higher risk of being diagnosed with dementia, even after controlling for other covariates. And the results from meta-analysis suggest that each additional missing tooth was associated with a 1.4% increased risk of cognitive impairment and a 1.1% increased risk of being diagnosed with dementia. So this paper also received a lot of national media attention. That CNN had a featured report, as well as BBC, then U.S. News and World Report. And my program officer, when I said earlier that who introduced me to oral health research, Ruth Nojek-Raymer, she actually was retired 10 years ago, but when actually has lost, we all lost contact with her. But actually during that time, I received a message from her. And she said that she saw this CNN report, and she was very kind of happy to see I still actually is kind of keep working on this oral health related research. And so that message actually really, I was quite touched by her message, to think about somebody actually did have a profound impact on my career development. That's somebody who actually introduced me and opened the door for me to think about kind of addressing oral health disparities, kind of conducting this kind of line of research is quite interesting, and that for close to decades that we're continuing working on this area because so much that needs to be done. And also in October 2021, NIA wrote a featured report that highlight our research findings, saying tooth loss in older adults linked to higher risk of dementia. So I'm glad that that our research is really can reach out to a large audience. So in the next few slides, I actually want to give you some of what we have been doing, looking at the co-occurrence of diabetes, poor oral health, and cognitive decline. So the one paper was published in the Journal of Dental Research, and looking at the co-occurrence of diabetes and poor oral health. The finding is also quite interesting. So here, before I introduce kind of results, so when people think about mechanisms, right? What are potential kind of pathways? Why there's an association between oral health and cognitive function? So certainly that if you look at this, these are some potential pathways that we can look at. Some common pathways between poor oral health and the diabetes is certainly potentially through chronic inflammation, through CVD, cardiovascular disease, and stroke, and some common pathways look at the dietary intake and the nutrition. But if you look at more so, there's a look at oral health as a kind of potential pathways, additional pathways between oral health and cognitive function, cognitive decline, and ADRD. There's some paper published looking at the bacteria and dysbiosis, the existence of this in periodontal among individuals with periodontitis have certainly can be a potential pathway to ADRD. And also some Japanese colleagues found that masticatory function and also this occlusal contacts that maybe actually that potentially can have an impact through these kind of pathways as well. So I'm glad that recently we received the funding from NIA, particularly looking at oral health and the subtype, and particularly aim to look at oral health and subtype of dementia, look at the pathways, focus on biological aging and the social determinants of health in this area. So we certainly will hopefully will tease out more test some pathways and tease out and show some mechanisms using empirical data. So this is a kind of a potential relationship. So a co-occurrence of diabetes and poor oral health. So for this study, our hypothesis is that this co-occurrence can contribute to accelerated cognitive decline among older adults. And also the impact of co-occurrence can actually vary across the age group. This actually very much kind of our hypothesis is that we test these hypotheses are valid in a way that we use a health and retirement study looking at 3 age groups. Sometimes we think that older adults have a look at kind of the continuous kind of age, right? Always treated age as continuous, but really sometimes it can be that there's a huge heterogeneity within age group. We may need to particularly look into whether it's young old, middle old, and the oldest old. There actually the relationship can be, and these kind of oral health and the diabetes impact can be very different. So our finding shows actually now this figure shows this 2 age groups. One is young old age group is 65 to 74, and then 74 to middle old is 75 to 85, 75 to 84. But oldest old, there was actually no significant association was found. So I didn't include that age group. So certainly that the figure depicts the cognitive function and the cognitive decline rate during follow-up for these two age groups. So on average, older adults aged 65 to 74 years has a better so overall have let me see the having edentrism only contribute to a faster cognitive decline for older adults aged 65 to 74 years and 75 to 84 years. Having both diabetes and edentrism actually to an accelerated cognitive decline for the group aged 65 to 70 years old. So separate analysis that you look at these two age groups that included the interaction terms for edentrism and diabetes showed that edentrism and the diabetes had a significant interaction effect on cognitive function only for those older adults aged 65 and 74 years old. So we found this co-occurrence impact on kind of additive effect that if you look at this age group, only for age group 65 to 74 years old. That's the dotted red line. That says a more accelerated decline in cognitive function. But if you look at this no additive effect in this age group for 75 years and above. But then you look at the blue line, the solid line, blue line, that is for those individuals has edentrism, complete tooth loss, but no diabetes. But if you look at this, actually their effect, the cognitive decline rate is more rapid than those with diabetes, but no, but have at least some natural teeth. That means actually to some extent for this group that the impact of a complete tooth loss even had a higher risk than diabetes. So what we all know, diabetes is a high risk for cognitive decline, but in our study, we found that edentrism actually is a significant factor that even could be potentially higher than diabetes. So for the young old, that 65 to 74 years old, the co-occurrence of diabetes and edentrism was not only associated with the worse cognitive function, but also with an accelerated rate of cognitive decline over time. But diabetes only actually led to an accelerated rate of cognitive decline only for the young old, 65 to 74. However, edentrism, the complete tooth loss, increased the rate of decline, not only among young old, but also for the middle old, that for this 75 to 84 years old. So edentrism actually had a higher impact in our study. So then I want to show you a recent study that we published this year that look at the gum treatment in the cognitive decline dementia for older adults with periodontal symptoms. So what we found is that here this study examined association of gum treatment with cognitive decline and the dementia among older adults with periodontal, evaluated effect across different demographic groups: age, sex, race, ethnicity, education, income. So here that we've this is the kind of we found this is a systematic review that actually no, that this is the health and retirement study. Look at the oral health dental module, then actually follow up. So we started with oral health dental module in 2008, then followed until 2020. So I want to actually, due to time constraints, I actually try to kind of just go directly to findings. So here we found that participants with gum treatment actually experience some 0.025 points less decline per year in tics score. TICS is the telephone interview for cognitive a score for it's an assessment. It's a measure for cognitive function. So dementia risk compared to no treatment group, 38% that the lower incidence of dementia for those that actually had gum treatment. So results actually was consistent across different periodontal symptoms severities and the most demographic characteristics. So overall, that the key findings shows that gum treatment may help preserve cognitive function for older adults with periodontal symptoms, and the significant reduction in dementia risk were also observed for those individuals who had gum treatment. So benefits seems across various demographic groups. So then actually we had also conducted a study, that's actually the systematic review study. I presented so many studies, sometimes can be confusing. So this study actually is a systematic review looking at association between oral hygiene behaviors and the cognitive decline in adults. So here this figure shows that toothbrushing was associated with a significant slower decline in global cognitive function over time. So, and that toothbrushing was performed by dental professionals and caregivers, whether this is formal caregivers, informal caregivers, was significantly associated with the improvement of global cognitive function. And interestingly, this has some policy implications here. There was no significant differences between the effectiveness of toothbrushing performed by dental professionals and caregivers, trained caregivers. So really think about implication for practice and the policies. This is that I think there's an urgent need for policy that promote oral hygiene care, especially in nursing homes and among older adults with moderate to severe dementia. So this integrating oral hygiene protocols into long-term care standards and providing training for healthcare professionals and the caregivers can be really important. So promoted twice daily toothbrushing could be a simple, cost-effective strategies, potentially reduce cognitive decline and many other health outcomes. So this is a study that we conducted using health and retirement study 5 waves to look at particular racial ethnic disparity in trajectory of dental service use. We used the health and 5 waves of health and retirement study from 2006 to 2014. So this figure actually visualizes age trajectories of the rate of dental service use. This figure shows that for both the US-born and the foreign-born, the trajectory of dental care service use tend to decline with age, increased age. So in this general pattern, look at was true for most racial ethnic groups that showed a substantial decline after age 80. Also, if you look at Hispanic, Black, and other racial ethnic groups, this is very much the case, that rapid decline after age 80. But for whites, however, their average level of dental care use showed a sign of a slight increase before age 80, and then the insignificant decline afterwards. So that's kind of, it is for both actually US-born and the foreign-born white population. So that's, so racial ethnic disparity in dental care was also substantial and persistent as people become older, regardless of nativity, whether you're immigrant or US-born, or adjusting for a wide range of covariates. So here that I want to spend a few minutes to actually think about how we kind of use an interdisciplinary approach to improve oral health in diverse aging population. So we actually just about towards the end of our data collection, we already conduct finished data collection. So we're into the phase of data analysis, is looking at the clinical trial care partner assisted intervention to improve oral health of individuals with cognitive impairment. So for this study, we have 3 in-home visits that we have dental hygienist as well as a nursing professional tiered up as a team to go to individuals' home. Actually, dental hygienist conduct oral health evaluation. Then our interventionist conduct this intervention that to improve their communication, to help them kind of managing, provide counseling of their caregiving, and also help develop kind of curing strategies for individuals. So we have our pilot study that was published a few years ago. Our pilot study found that the oral health of the participants in both treatment group 1 and the treatment group 2 improved. So we gave treatment group 1 is just a smart toothbrush, recording oral health behavior, hygiene behavior. But treatment group 2 is, in addition to give them smart toothbrush, we also have individualized in-person counseling and these kind of intervention. So both the treatment group 2 from our pilot study showed a slightly greater improvement in their oral health status and oral hygiene outcomes. But in the we included both MCI and the mild cognitive impairment. In the MCI group, participants in the treatment group 2 had a significantly lower percentage of sites with plaque than those in the treatment group 1 at a 3-month period. Plaque is one indicator for the quality of oral hygiene. So this study, we have finished the data collection now in the phase of data collection, and we will certainly share more results from our this clinical trial study in the future. So in the next few minutes, I particularly want to actually think about potential strategies in terms of that we're in the phase of how we can strengthen our public trust in science, and also in these areas of kind of oral health that enhance transparency and open communication is particularly important. That engaging community outreach and the partnership, I really kind of think it's important for our scientific community, our scientists to reach out to community and work with our community partners to disseminate research findings. And you also using lay languages to disseminate our study findings. So that's why I am co-leading this 2 NIH-funded center grant. So we actually now asking for our pilot scholars research findings. We're actually trying to come up with some like 1-page or half-page kind of a summary of the research findings using lay language, and trying to actually distribute to our community core, community engagement core leaders to actually help distribute findings. So these are kind of, I think it's important in a way that how we can reach out to community and disseminate findings. And also leverage digital platforms. We should not train ourselves to write scientific papers, but also we can write kind of co-op kind of papers in newspapers, in social medias to distribute scientific findings. And certainly we can actually in policy advocacy and support. That's also important. That from dental clinic, so here is a kind of traditionally we receive dental care service at dental clinics, but for our aging population, there's a trend to think about how to from traditional delivery model to a more alternative delivery model. The importance of interdisciplinary collaboration in the transition from traditional dental clinics to alternative delivery models, like ensuring comprehensive and accessible dental care for diverse population needs. So for example, that skilled nursing facilities and assisted livings, dental professional can work closely with nurses and the caregivers to tailor care needs, right? And also think about home care. So home care, that dental providers can partner with home healthcare teams to deliver convenient and effective treatment for older adults with mobility limitations. For caregivers and the families, the training and the engaging caregivers or family members in oral hygiene practices ensure continuing of care, especially for individuals with disability or chronic conditions or cognitive impairment. In the mobile dental clinics, this kind of model requires collaboration among dental professionals, logistic teams, and the community organizations to bring services to underserved areas. Telemedicine, that how we can effectively implement effective implementation depends on partnerships with technology developers, healthcare providers, and the policymakers to overcome barriers to virtual dental consultations. So these are kind of things that how we can expand our dental care delivery models. So to fully utilize the non-dental professionals to improve oral health for older adults. There's actually at GAC Oral Health Group, we published another white paper that based on our one-day workshop with 36 national organization representatives. We gathered in Washington, D.C. in 2017. And later we came up that all these representatives came up a lot of suggestions. So this white paper is a GAC work group wrote this white paper on interprofessional solutions for improving oral health in older adults. So here we potentially provide some kind of potential solutions in Medicare coverage, Medicare expansion. So this is actually really kind of think about a hot topic, think about how we can have a Medicare expansion to cover eyes, vision, and dental. These are kind of three coverage which are not traditionally be covered by Medicare insurance. Getting people to care about oral health in older adults, then drive awareness of the economic and humanistic value of better oral health for older adults through health promotions and the public relationship campaigns, targeting consumers, caregivers, health professionals, other oral health champions, and the caregivers, researchers. So that practice of the future is really about integration. The integration of oral health into general health, change dental care delivery system from care delivery silo to more general and robust healthcare system. Think about make oral health as a part of primary care practice. The change the scope of dental practice from dental. It's not only about your teeth. It's about the oral health as a system. Excuse me. Integration of dental and the medical education. And also actually NYU College of Nursing actually is one of the pioneers to think about how integration of dental and the nursing education and integrate finance, then interprofessional practice as well. I would like to acknowledge my team members. It's certainly many, not so as I'm trying to be inclusive, but most likely to have left several, many others, that this is truly a team effort to have generated a significant amount of fundings in these areas, think about aging, cognitive impairment, dementia, and oral health disparities. And also, I would like to thank NIH, NIDCR, NIA for continued support for the past 2 decades. Thank you very much for the support, and thank you for listening.
Thank you so much, Dr. Wu. Really wonderful and interesting presentation. I do have some questions myself, but we have several in the Q&A, so I'll keep my questions for if we have any time left. So I'm gonna go to the first question, thank you for your talk. If you had to recommend a psychometrically robust self questionnaire of oral health for you in clinical research studies of older adults that don't focus on oral health, what would you recommend?
Yeah, we actually presented a paper at the GSA, particularly actually a systematic review of oral health related quality of life measures that if you can send me a message, I'll be happy to share our research findings. We are in the phase of submitting this manuscript, but we already presented at the GSA that, for example, one measure is on GOHI. It's a GOHI, GOHI. I'm now blinking on the name, but certainly if you send me a message, I will be happy to share that if you look at the publication and you have this, will be the slide will be shared with you. We actually use GOHI, yeah. So GOHI we used in our West Virginia the data collection in West Virginia that is geriatric oral health related quality of life index. So this one we found that actually has good validity and sensibility of for older adults. We also use some of the measures in our recent studies. Look at PINE. Actually, PINE, I mentioned the PINE data is for Chinese immigrant population. We use some of the measures from GOHI, but we didn't actually particularly use the full measure because it's a large questionnaire, so only can capture include a few items. So these we are into this and trying to make a kind of a clean systematic review on these measures.
Great. We have a couple of questions related to junior investigators or people new to the field that are very interested in the field. So they're asking what are some unanswered questions that new researcher in the area can pursue and also establish themselves, given there's a lot already done in this space by leaders like you. And if you have any advice for junior faculty that are interested in this exciting area of oral health and aging broadly, and oral health and cognitive health specifically.
Yeah, this is a good question that certainly what we have known is certainly this that we have conducted, and this field has conducted a lot of research in look at association, examine the association between oral health and cognitive function and dementia. But we don't know is we still lack of large cohort data, look at the changes of oral health status in relationship to changes of cognitive function. We certainly have a great number of cohort studies that over time longitudinally we can test the like a decline of cognitive function, a rate of cognitive function, but we have so few studies actually look at large cohort studies look at the changes of oral health status. And particularly, there's, as I mentioned earlier, there's only NHANES is the only study has clinical examination of oral health studies. But there's that even for HRS 2008, actually, I developed that oral health module. That was actually I developed for HRS, and we have this included some, still it's a self-reported oral health measures. That's why back to the previous, the first question was quite relevant. How if for large cohort study, clinical examination is very costly. So we do need to think about using some valid oral health related measures to be used in large cohort studies. So then we can look at the changes of oral health status in relationship with cognitive function. But this is one part. But also we don't know is there's so lack of clinical trials RCT or clinical trials to look at this to test the causal relationship between poor oral health and the potentially kind of related the cause, whether the cause cognitive decline or vice versa. So that also clinical trial. So now it's so wonderful to have NIA program officer, and the NIA hosted this a session that I really I'm a strong advocate to think about whether NIA can be a pioneer to allocate more resources and funding to look into this area. Yeah.
Great. And do you have any like recommendations, suggestions for more junior faculty who might not have big fundings to start doing like a longitudinal, like large cohort study? Who's interested still in doing research in this area?
Yeah, you can still have actually to conduct some secondary data analysis using, because this field is still, there's a lot of unknowns that you can still do, but also that encourage you to think about some ancillary kind of a study that tap into existing large cohort study. So this can also be an interesting kind of idea that NIA, that if you can actually have a kind of call for proposal to think about these using existing leverage existing large cohort, ongoing large cohort, but having this oral health as a supplement, as a kind of conducting this kind of research can be quite interesting as well. So
great, really good advice. Okay, so the next question about the data that you presented, did you control for other health conditions in your analysis? And is oral health independently related to cognition over and above other conditions? I'm wondering if oral health is just a proxy of overall health.
good question. Actually, that all our studies that being conducted, we're trying to controlling for all other potential health outcomes. So we, for example, that when you look at this dental one, that co-occurrence of diabetes and poor oral health, we included many covariates. And we found that interesting, the oldest the impact was not exist. There's no significant association, but younger age. But that's actually related to that. The one point I want to make is just today, yesterday I was, my colleague and I was writing a response to news reporters that we just recently published a paper looking at the age of diagnosis of diabetes and in relationship with the risk of dementia. We found the younger the age of diagnosis of diabetes, higher risk of onset of dementia. And for those individuals younger age, younger than 50 years and older, that actually, if they are also obese, that is a 3 times higher risk than those individuals who diagnoses diabetes at the age 70 and older and without diabetes. Now, that as we're finding, so we can clearly show the importance of prevention at a younger age, that this is something that we need to think about, and our study clearly shows some that at a younger age you show this kind of poor oral health and the diabetes impact on cognitive decline. That actually is relevant to what we I just that paper that our team published as well.
So the next question, what is the state of oral health for Asian American immigrant geriatric population? Are there disparities in that population?
Oh, very much so. That's actually, this is such a interesting question for Asian Americans that I can actually have another a talk, because we have conducted quite a few studies looking at national data, looking at the data that we collect on our own, and looking at the systematic review. The picture is so different. when we're using national health and nutrition examination studies, we found that Asian Americans has such a better oral health than all other racial ethnic groups. But when you look at, for example, PINE data, you found that there's such a high prevalence, 66% of older adults, immigrant older adults, report oral health symptoms, ongoing, untreated at that point, oral health symptoms. But then you look at some other, then that's why it's such a different kind of methodological issues, recruitment issues. Think about where you conduct a study, how you enroll participants. There's huge disparities within Asian populations, huge heterogeneity of the Asian population in terms of the socioeconomic status and the health outcomes. This is something we really need to disaggregate the data and conduct a more kind of into subgroup analysis.
Okay, the next question, I don't know how much more time we have, but I'm just gonna read this next question. This is a follow-up to what we discussed before about using the existing data and doing secondary analysis. So the question is, how can we obtain the data for secondary analysis?
Yeah, most of this secondary data are publicly available, but some data, it's a restricted data, then you can apply for the access. Most of this is free of charge. So like a health and retirement study, this is so well known, right? And hence all these public available data. But then that all the instructions are online, you can apply for restricted data. But certainly you need to kind of train or collaborate with others. Secondary data, there's a lot of coding, data management, these kind of skills need to be in place so you can conduct these kind of studies. Yeah.
Great. So we are out of time, but we still do have some questions in the chat. But I think Camille put Dr. Wu's email address in the chat. So please email her and follow up and ask all of your questions. And now I'm just going to hand it over to Camille. Thanks.
Thank you so much, Miriam, for moderating the chat. Lots of questions coming in. So this was a great topic. So thank you once again to our speaker, Dr. Bei Wu, for presenting today. If you would like to follow up with Dr. Wu, I have left her email address in the chat. I will also be sending you all the presentation slides and the recording probably next week. And so, yes, thank you again, Dr. Wu, and I hope everyone enjoyed themselves today for the presentation. We will follow up with you all very soon. Thank you so much. Have a great rest of the day.
Thank you, NIA, for the support. Yes.
Thank you.
Great. Thank you. Have a great day, everyone.
Yeah, bye-bye.